Today on Stronger Bones Lifestyle Podcast, I have Dr. Jeff Gross back to speak with us. I've interviewed him a few times, and he brought up a lot of important information around the system of healthcare, actually the broken system of healthcare. So for all of you that are delusioned by your doctors offering you just pills and nothing else, and are looking for answers and some more information, this is a doctor that's going to talk to us about the system, what's going on with the system, and what we need to be aware of or knowledgeable about so that we can make the best decisions possible for our own health. So on Stronger Bones Lifestyle Podcast today, I brought back one of the most popular guests I've had that I received the most questions about, a lot of views in the shorts that we put together for our episodes. And so today I am welcoming back Dr. Jeff Gross.
Thank you so much for having me. It's great to be back.
Yes, great. So Jeff, here is, I call you Jeff, right?
Yeah, of course.
Okay. So you have really stimulated in me, I think I told you this off camera, but when my very first interview with you, I try to be cautious because I interview a lot of physicians. They have a license to protect. And although I love to hear controversial stuff, I want it to be that it's okay and safe. And so you, when I first interviewed you, you were just talking about big pharma, big healthcare, the big system, the thing that it is frustrating to all of us. And so that's one of the main reasons. Well, I mean, I love to talk to you about everything, but that I really thought it would be nice for us to discuss kind of what's happening out there, like what's going wrong with healthcare.
Yeah. No, thank you. Thank you for that. Yeah, of course we have these licenses, but more important than the licenses is I took an oath, and I wouldn't have taken that oath, that Hippocratic oath, to protect my patients and do the best for them and not be closed-minded and limited to what the licensing bodies force down our throats. Had I not been inclined to go into medicine because of my love for the fellow man, right? And that oath is more important. And I've been through a lot of craziness. I've had colleagues who are driven to mediocrity because they're safe there and they do what the insurance companies tell them to do or will pay for. They do what the big organizations tell them to do. They follow Big Pharma and the latest drug for a disease that didn't exist 10 years ago but exists now because now there's a drug for it. So I'm just, I guess maybe I'm older, maybe wiser, maybe thicker skin, and I'm more afraid you'll find me buried in the desert here in Nevada. You know, that's what we say when you disappear. But, and it's happened. That stuff happens.
I have that same thought of myself, to be honest, because I'm really disruptive, want to be very disruptive. I completely want to globally change not healthcare, but bone healthcare, really, truly. And I'm on that mission. And I do wonder, oh, will Debbie just go disappear one day? But if I do, that's okay.
Yeah. No, we can't disappear. We need people like you, and we need to do this for patients and for people and for the well-being of our community. And this is the right thing to do. This is the righteous thing. And we have to speak the truth and not let others force truth upon us that's not really the truth.
Right. So kind of let's go to, because I think that where all this begins, and correct me if I'm wrong, because I deduct from conversations what I believe to be the case, but you're in it, so I'd love to hear your analogy of it. Does this all begin in medical school training?
Yeah, but it stems further back than that. It has a history. Early in the 1900s, medicine was whatever you wanted it to be, snake oil and this and that. There was very little organized science behind it. So there were competing thoughts, allopathic medicine and osteopathic medicine and chiropractic medicine and all these things. And there was something called the Flexner Report, which was commissioned to look at how do we move forward with medical education. And I guess it was sponsored by, and I'm sure someone will write in and correct us, and I accept that. So, because I'm telling you what I think I know. It was sponsored by the folks who had petroleum business, big money petroleum business, looking for uses for petroleum extracts and other byproducts of the petroleum industry. They wanted to use every last drop of everything from the oil from the ground. So that's where the Big Pharma, I think, sort of came from. And the medical education was then sponsored by a lot of that. So the And then we just got in this sort of self-perpetual cycle in the medical education side of what we learn and what we were supposed to regurgitate. And the education is so long, right? You have 4 years of medical school. You have many years of postgraduate training, residencies. And mine was 7 years, but it could be probably on average it's 5, and very few are more than 7, but they can be. And all those years, you get this pounded into you. This is how it's done. This is if A, then B. So a lot of that is disease drug, disease surgery, disease implant, that kind of thing. Even if the disease doesn't exist 10 years earlier. It's crazy, right? So, and we're seeing a lot of that now.
Yeah. And, a couple of things about what you said there. So one thing that I notice is along that process became research. So when they were trying to find the pill for the disease, they wanted to research it. And so if you take one pill and you're taking one mechanism of the 70 trillion cell being, one mechanism that you're trying to isolate everything, keep everything else constant, and then you have one variable, which is this pill, where does this pill actually, affect blood pressure or whatever it is it's trying to do? And if you look at it for that period of time, probably it is going to do that. But this doesn't stay constant. And you don't allow for so many external factors to get involved. But what has happened, what I believe has happened, is that we hang our hat on evidence-based, double-blind, randomized trial studies. And when we do that, somebody just asked me recently about food or about a supplement. And I said, how could we answer that question? Like, how do we know what happens to a vitamin when we take it and it goes in our mouth? Where does it get absorbed? How much of it gets absorbed? How much of it does your body need? How much of it does your body use? What are all the mechanisms that gets in the way in that process? So I think that out of this came this attachment to evidence-based research, which is funded by and is better quantified and legitimized when we're doing it for a pill or a medication.
Yeah, let's debunk some of that. I think that's important. So the phrase evidence-based medicine or evidence-based research is misused, right? Because everything has some evidence if you look at it close enough. So in this whole concept, like you brought up, that only randomized, blinded trials are appropriate, no. A lot of what we do as doctors is based on observation that comes from no study. Certainly not a randomized, clinical, blinded, placebo-controlled study. No, those are the highest quality studies because you remove a lot of variables, like you said. But those are impossible to do in many settings. And if you wait around for a double-blinded, controlled, placebo-based study like that, you will miss some preventative or some attentive care that you could have tried or done for a problem or prevent a problem while waiting for that super evidence. So you can be a little over a sort of a curmudgeon on that type of thing. So you're right. It's a little bit crazy. And to be fair, half the research out there, including placebo-controlled, double-blinded, randomized studies and things, are crap. I mean, we talked about this briefly last time, the Women's Health Initiative. Thousands of, patients that were looked at completely wrong. And I'll tell you maybe it's a funny story. It's funny for me, but when in medical school the last year, most people are off doing rotations at other institutions. You're kind of not around that last year. You're looking at institutions, a place where you might want to do a residency. So, in fact, I think I sublet my apartment that last year. And then the problem is then it's time to graduate and people are like, I'm tired. I've had it. I don't want to have to go back. So they created this 2-week course, 1 or 2 week course. At the very end of med school, you had to go back for it. It was mandatory. And no one wanted to go back. And it was just, back in the classroom. And it was how to study a study, how to test a test, I think were the name of the books one professor had. And it was this critical thinking, and we were all just bemoaning it. But now it's probably the most important thing I had. So thank you for making me come back and walk through graduation and do all that. And that's where you take the Hippocratic Oath anyway, so we had to do it.
Yeah, it's so interesting because Mark Hyman, he's one of the first physicians in the functional medicine space. And one of the things I thought that he did so well is he analyzed studies. Because for the layperson, someone who's not trained in this, it is so hard to look at a study. To all of the, I don't know which parts I should look at. What I usually do is look at the beginning. Is that the abstract or the top part? Yeah. And I look at the last few lines that kind of say, and this is what we found in this study,
Yeah.
for the thing.
And they don't even say it now. It's garbage. They're so poorly written, and they've changed how they look at these things, and the peer review process is political. It's nonsense.
Yeah, it's so sad. So my population, let's say 50 plus, but especially women in the 60s, 70s, 80s, when it comes to bone health, really ingrained and enmeshed in the beginning of this control of big pharma and big healthcare, whenever that happened, probably like 90s, right? 90s, 2000s, and now into the 2010s, all of it, right? And so they're just so attached to this. One woman today, I just taught a class, and she wanted to ask me a question about BHRT. And I'm like, yes, that's the most preferred recommendation in the bone health space by functional physicians. And she said, well, I'm not going to take anything orally, though, because I looked, and in my family, someone somewhere had cancer. And I said, but actually, it doesn't cause cancer. That study, the Women's Health Initiative that you're referring to, was actually not peer reviewed. They used synthetic hormones, and they administered it incorrectly. And I said, and you do have to take progesterone orally because of the metabolism process. So there's the aspect of, first of all, we try to listen to all of this. That's what it is. It's the attachment to that. And then that's where we go wrong.
The Kool-Aid I spoke to last time is not just for doctors. It has spilled over into the patient side, right? You have all these doctors saying, oh, that causes cancer. And then you've got patients now who are regurgitating that, or they heard it somewhere. And you have to take a fresh look at things, because you have to come at it like, okay, a lot of things were wrong. What makes sense here? Let's look at it again. Let me get multiple opinions. You have to get multiple opinions. You have to get it from maybe a wise, elder, experienced physician, maybe a young, fresh out physician, maybe someone who's a non-physician but is in the health and wellness space, who's looked at it. Sometimes it's a non-physician who's looked at the research even closer than doctors. Doctors don't have a lot of time for that, especially if they're practicing in the Kool-Aid driven system. It's laborious. It's bogged down by insurance, administrivia, phone calls, peer reviews, nonsense.
Yeah, and you use the word Kool-Aid, right? So I'm going to say that this, let's say maybe 30s and below, maybe 40s, I don't know. They might not even know what Kool-Aid is, right? I grew up, the 70s, I think, was Tang and Kool-Aid and all that, right? So I was born in the 60s. So, but my population does know about the Kool-Aid. So my population is the group of women that are going to adhere to that and listen to their doctor. So I think that I see two different things happening here. I see my population, 50 plus, 60 plus, that they really respect their physicians. And this is why I'm so glad I have this podcast for physicians like you and all the other physicians that I have that validate what we're speaking about here. But the younger generation, they're actually becoming disillusioned with their doctors and not trusting their doctors because of this understanding of like how we've been, misguided and misled, really.
No surprises there. I mean, they're right to question it. They should question it.
Yeah. Okay. So something else you just said. So you were talking about the Kool-Aid. I thought about the Kool-Aid.
Do we need to explain that? Should we explain where that comes from?
Yeah, maybe, because I do think that there is, I wonder if my kids are in their 20s and almost 30. I wonder if they know what Kool-Aid is. I didn't serve that disgusting, poisonous, sugar-laden, and what else? Fake artificial colors.
Oh, yeah, which are now coming off the market all of a sudden. But yeah, well, Kool-Aid is obviously a brand of a fruit-flavored artificial beverage for, kid-friendly. But there was a cult, and the cult, was this the one in Waco, Texas? I believe that
Jim Jones?
Yeah, I don't recall, but needless to say, it was a cult, and they were being surrounded, I guess, by federal agents. And so the cult leader said, everyone needs to come drink this Kool-Aid. It'll be good for you. And he poisoned it, and they all died. So when we say drink the Kool-Aid, then you'll believe anything you hear is what it really means.
Yeah. Yeah, and that is what is happening. So what do we do? So because we want to respect the doctors, that's the whole thing here. What I don't want to happen, and as I raise awareness around this topic and have these discussions, women say to me, they're frustrated. So in the bone health space, usually it's endocrinology or gynecology. And they're going into their doctors. And what one orthopedic surgeon told me is he's not even practicing medicine like this anymore, because at this point, There is so little funding. He gets such a small amount of money per patient that he has to actually only spend 10 minutes with the person. And if he's spending 10 minutes and has to figure out all of these things to suggest or recommend, then on the EMRs, are they called EMRs or ERs, medical records?
EMR, yeah.
Here it is popping up. It makes it easy for you. Fosamax or Prolia or Avinity. It's popping up. Here's the drug. This is what she needs. This is what she needs. This is what she needs.
Yep.
They're so frustrated because then the doctors are getting frustrated and they actually are, I'm going to use the term, becoming bullying or pressuring women, like threatening them, threatening. If you don't take that pill, you might fracture within a year. Or one doctor said, good luck walking out to your car. It threatened her walking out to her car. How fragile do you think that woman feels about her bone health if this doctor is telling her she better be careful walking out to her car?
Debbie, this is not the practice of medicine. The practice of medicine is not a 10-minute encounter. It's not a computer-scripted cookbook encounter. It's not an insurance-driven encounter. The practice of medicine is a complete history where you take down all the details. It's an examination with your hands on the patient. It takes more than a minute. And then you look at the test, and you do what's called a clinical correlation. We put it all together, and then you give the options, and you give the risks and benefits of the options in a process we call informed consent. And then you act on those based on the agreement of that intimate relationship between doctor and patient. Anything else is not the practice of medicine, and those are medical imposters and should be called out for that.
Well, what I would like to suggest, though, is that you say they should be given options. So if in the training, the only option, so I'm just speaking about the bone health world.
Yeah.
The options given to the physicians are the classes of medications, vitamin D, and calcium supplements. So in all fairness to those going through that training 30 years ago that are now most of them in their 50s and 60s, the physicians, actually that's not true because even some of the younger physicians, this is the same case. That wasn't options that they were offered. There was no lifestyle options. There was no nutrition training, no talk about optimizing sleep for bone health or stress and thinking about the hormone cortisol and how that's a bone dissolving hormone and how, wait a minute, why don't you get her to stop that? Because in Western medicine, we do not look for the why, we look for the what. And when we find the what.
For the why.
Oh, really?
Well, you're right. We can look for the why, but it takes, doctors are meant to be critical thinkers, right? The tests to get into medical school require that. So, and a lot of the tests and the boards to get through the medical training and the certifications require that. But then these electronic records and scripting and what insurance will pay for and how that cookbooks it down has dummied down medicine. That doesn't mean that a good doctor can't still do the right thing. And we're aware of nutrition. We're aware of cortisol. We're aware of lifestyle and inflammation, all these things. And just because it's not something you want to take the time and do is not an excuse. A bad practice just because you're busy filling out your checkbox on your computer and get through to the next patient and see more patients an hour because that's what the insurance is driving down your throats. That's a bad decision to accept that insurance payment. That's what's happened here. The doctors are the problem because they need to say no to this crappy economic. They need to say no. And when we start saying no, the economic will improve for those doctors, and then those doctors can spend more time and actually practice medicine. Think, act, be comprehensive, be thorough. And that's why I gave all that crap up a long time ago and refuse it, because I can't carry out my Hippocratic oath doing it under those stringent constraints.
Yeah, I love that. And hopefully that is going to happen. And I don't know what form or format that's going to happen in. I think that it is kind of happening. I think I mentioned off camera that I think things were different 4 years ago than they are even now. Today in my class, I told the ladies that I was going to be interviewing you, and I said, are there any questions you have for me? And one woman said, yeah, can you ask him to, because what's happening is right now there's either you're going to do insurance-based medicine, you're going to be stuck in this, see a patient for 10 minutes, only get $120 or whatever it is per patient, so that you cannot even run your office staff or run your business and pay your malpractice insurance, right? So that's what has happened to physicians at this point. So that's what's happening there. And so if the physician leaves that model and no longer accepts insurance, now they're going into either a concierge practice or a direct pay practice. And that can run a pretty penny. So there can be, $15,000 programs, 10,000, 8,000. And there are people that can afford that, and that's great. And there's that. There's also the ladies that are on Medicare that don't really have the means, or I don't even know if it's the means. I'm trying to raise awareness to, and this is what I said in class today. We have to pay for health. We have to pay outside of healthcare. I know you're happy that you got on your Medicare, and that can be for big things. And one woman suggested take the cheapest one, which is the HMO, and then use the extra money you have to go outside. So what she asked me is, can you ask him today if he could create something? So there could be the big ticket programs, but can we create something where it's more of a group, where questions could be answered and it'll be less expensive? And I told her, I said, well, that's what I want to do, is I want to create group-based programs. I said, however, if it does need to be individualized at any point and the doctor has to look at you and see you as a patient, that becomes a whole different level.
Yeah, so this was a coming conundrum in the last 30 years. 30 years ago, Medicare was a perfect payer, right? They have not really increased what they pay over the years, so the cost of delivering the care has crossed that curve and gone way up, and Medicare has paid the same. In fact, they want to drop a little bit every year because there are more and more people in that system, but not enough dollars to go around. So it's a problem, and the problem could have been predicted years and years and years ago, but politics and what have you just prevented it. So, and then there was a while where, okay, doctors maybe make a little less money seeing a Medicare patient, but it was okay because the other private insurances paid decent, and we're not good businessmen as doctors. You take the Hippocratic Oath, everyone gets taken care of, but we pay off our loans in the wash, it works out. But then Obamacare came, and Obamacare said to private insurance, we got you guys. You can now get by charging Medicare rates, or paying Medicare rates. So now most insurances, even patients will walk in and say, oh, doc, why don't you take my insurance? I have the best insurance. And no, you don't. Trust me, you don't. They're paying Medicare rates. Maybe they're paying 5% more, 5% less. Everyone's paying Medicare rates. So now no one's paying. So that's why you see hospital systems who are already federally funded in some way buying up all these practices. I was at an event this past weekend, and a hospital chain board member came up and we started chatting. He goes, yeah, I work for a hospital chain. We've bought all the medical practices in our area. We own medicine in our area in Florida. And I just thought, wow, you control every EMR, every click box, every drug. And where the insurances really crush you is the pharmacy hassle, right? Do you know how that works?
No.
Debbie? So let's say you do need a pharmaceutical for some reason, and it's legitimate. It's not just a statin because your cholesterol was mildly elevated, right? It's something you really do need. An antibiotic, let's say. Oh, the insurance won't cover it. You have to go to a different pharmacy. Then you go to that pharmacy. Oh, they haven't approved it yet. And you're in this hassle stream. They're calling the doctor's office. The doctor's tied up, and the patient's upset. And we're taking it on the pharmacist or the pharmacy tech. And the people in the insurance company are sitting back in their yachts laughing. They've created this like Keystone Cop situation. And maybe some of the listeners don't know about that. You think about like these black and white shorts where you have these bumbling policemen. It's a kind of cartoon style, just not knowing what they're doing. And that's what's happening. And some pharmacy benefit manager has made some contract where they're making tons of money at the insurance level, but the patient can't get what the patient needs. The doctor is tied up and frustrated and losing time where they should be seeing patients, has to hire extra people in the office, bogging that office down in this craziness. And no one's happy except the insurance company. So I say you get as far away from insurance as you can. And this comes down to, is healthcare a right or a privilege, right? So, many people have paid into the Medicare system over the years. I'm one of them. You're probably one of them. And we want that service back. And that service doesn't really exist very well. That's the problem.
Yeah. So, okay, I have three. There's three of us I pay healthcare for. $3,500 a month is how much we pay. Now, that's not for the office visits. That's not for any kind of medications that are needed. It's really, so what do we do? Because I've thought about this. Like, do I really need healthcare? I spend so much of my awareness and focus on prevention and on lifestyle, optimizing my lifestyle so I won't get sick. I have an infrared sauna. So I spent money on that. The minute I feel like I have a cold or something, I think, let me go fry whatever it is inside of me. So I'll go in my infrared sauna. So what do you do if you don't have health care? I mean, if you go to the ER these days, it's bogged down with people that don't have health care. So
you're right.
What do you do? Should we do like the lowest level available just for catastrophic things?
Yeah, that's what I recommend. You pay the least, get the highest deductible, the catastrophic program, so if you're hit by a bus, you're taken care of. But for most things, maintenance and general checkups and health, you really should take it upon yourself. You're going to do a better job anyway. Take it upon yourself. Find one or two providers that you trust who spend the time and pay for it. And you'll pay less per year. You'll be healthier for the most part. And anything that's really expensive is covered on that catastrophic plan. That's what I recommend. High deductible. I love these flexible spending accounts or health savings account programs where some of the money is set aside by you in a tax-deferred account. You can use that any way you want for an infrared sauna, for stem cells, for whatever. You can use that, and you can do it. It's like a cash payment.
Yeah, and from a business perspective, because I always say, like you said, they're on their yachts. I'm like, oh, they're all on the golf course together in the golf country club having lunch. It's so true. It's like we've been playing Monopoly. And when you play the game of Monopoly, and hopefully everybody knows what Monopoly is, but that whole last line where Park Place and Broadway and all the green, Marvin Gardens and whatever else, when someone gets on that and has all of the houses and all of the whatever, they condominiums or whatever on their hotels, you can't even play anymore because if you land on it, you cannot afford to do it. So it's almost like that's happened. It's a broken system. Now, if you do the Flex account, the other thing about this that is people aren't thinking about is that prevention and living healthy is going to put you in a place where you won't even need those things. You won't even need, you could take that money for acupuncture, for infrared sauna, for good high quality supplements, for stem cells to avoid, or exosomes,
yeah, you got it.
Exosomes to avoid surgeries. You know what's really crazy? So because I have a hip replacement that I had at 51, I know what that's like. And I was young, right? 51 is young and I was fit. They are actually sending 60-year-olds, 70-year-olds home the day they have the surgery.
Yeah. Yeah. Because they don't want to pay the money to stay overnight and be watched by a nurse and stuff. Yeah. It's a rough world. Kicking people out of the hospital. I watched that my entire, when I did a lot of things in the hospital, but I stay away from hospital. That's where the sick people are. And plus it's controlled by the machine. And I'm trying to stay away from that. But if you need something, if you need a stent or a heart procedure or something else, leaving the country is a great option because you can get health care for a lot less money cash in almost every other country.
Okay, so the question today, I asked the ladies, what questions do you have? Somebody asked me this question. She said, can you please ask him? A lot of people are going down, like somebody had spinal stenosis and they went down to Mexico and they got treatment there and now they're doing fine. So is it safe, especially when we talk about injectable things or surgeries, when you do stem cell and exosomes for that, healthy aging regenerative medicine, is it safe to go to Mexico and have that?
Well, let's start with general treatments. So we'll come back to stem cells because I may address that separately. You got to vet the clinic or the hospital or the doctor. You got to check the reviews and the cleanliness and all that. And it doesn't have to be Mexico, right? That you can go to Singapore and they'll take good care of you. Turkey. There are a lot of things online. Check it out. A lot of people go even to the Middle East. They do all kinds of dental procedures. I had a physician friend who went to Costa Rica for dental care, big dental care, implants. Paid a fraction. It turned out to be an expat dentist anyway, American dentist. So look for it and get a trip out of it. Go see a place in the world you've never been. In terms of Mexico, it just depends. Now, on the stem cell side of things, I don't know the screening of the donors. I don't know how many lineages were passed. I don't know if they've been COVID vaccinated or not. So I like a little tighter control over that since I'm deep into that personally, but there are good clinics everywhere. I've visited personally a stem cell clinic in Cabo San Lucas, and A, I love Cabo San Lucas, and B, it was wonderful. They had a beautiful lab. It was certified. I spoke to the physician at length, and this is a place I could work. So there are reputable places, but you do your homework, just like you should do with your doctor here in the States.
Yeah, that's good to know. And I think sharing this information raises questions and opportunities and options that we maybe didn't think of. Because it is a broken system. And I think that when I did my yoga therapy training in a clinic at the Venice Family Clinic, I think it's the largest clinic actually in America, the attending physician there, he said that the system is broken and we're not going to be able to fix it and we have to go around it or on the outside of it. And this is kind of what we're speaking about here is don't expect it to work for you because it's a monopoly game that's already we're not going to fix it.
Yeah. No, I agree. The money in the system is pulled out by the third-party insurers. So until they should be capped like a public utility, right? The water company can only make whatever 5 or 10% profit. Here in Las Vegas, sometimes we go to the hockey games and the power company advertises. Like, why is the power company advertising? Is there a competition? I mean, like, do we have a choice? No, we don't. Like, why are they wasting money on advertising? I'd rather you lower my electric bill. So the same thing in health, right? You have CEOs of major health insurers making $100 million bonuses. I know this is controversial, but someone got shot and killed in part. That shed light on that. No one should get shot and killed, but we need to shed light on this. That was probably the wrong way to do it, but we need to shed light on this. And they should not be making that much money off of everyone's illness, sickness, preventative care. That's ridiculous. There's plenty of money in the system. It's just getting sucked out. So before mid-1980s, that wasn't allowed. And some legislation changed, and that needs to get flipped back.
Yeah, you use the word profit. And that's whenever there's profit, whenever, like you mentioned, the company in Florida, when they buy out, let's say, 10 facilities, it's no longer each individual person in each of those facilities. It's not the human part that is monitoring or observing or even overseeing or noticing.
Right.
It then becomes the profit and the people sitting in the boardroom looking at numbers, not looking at human beings. And that is where things have gone wrong.
It's called the corporate practice of medicine. It's largely illegal, but it's cloaked, so they get away with it. Plus, they have these huge lobbies, and they can, affect the law by how lobbyists do that. I'm going to be cautious here. This is how I end up in a ditch in the desert.
Yeah. I was at a wedding, and there was a man behind me, and he said, lives in Washington, D.C. And I said, oh, are you a lawyer? Nope. Oh, are you a politician? Nope. I said, oh, you're a lobbyist. And he is, and he works for healthcare. And he just said to me, like, I thought, ooh, should I have him on my Strong Bones Lifestyle podcast? Should we talk about this?
Yeah, you should.
I don't know, though, that he would be up for that, especially because there's video involved. I'd have to put a bag over his face and distort his voice. He just said to me, you can't believe what goes on. And I said, I actually can believe it.
Yeah, we
because we're experiencing it. I experience it with the ladies that I work with, that I hear from, the discouraged aspects, the women that don't know what to do. They're being pressured with just a pill. And unfortunately, in the bone health world, there is such a limitation on what was the word you used not options. Did you say options? What was the word you used about what you're supposed to do as a doctor when you give somebody?
Yeah, we're supposed to go through all the available options.
Yeah.
And we're supposed to go over the risks and benefits of those options, pros and cons of those options, so that we help educate patients to make the best decision as a team. It's their decision, but we have to guide them. That doesn't mean we scare them walking to the car. You're going to break your hip walking to the car. But we need to go, hey, you're at higher risk for fracture if we don't take some intervention or something. Like, there needs to be a reasonable, logical, unbiased review of those options. Tell people, here are all the options. Here's what I would do. I can say that, right? here's what I would do and here's why I would do it.
It's so interesting because I don't necessarily have a structure for this interview with you. I wanted it to be very conversational, and you're saying something that's taken me to, oh my gosh, and let's go to here. So one woman in my world is on a PPI, protein pump inhibitor. Well, protein pump inhibitors stop digestive enzymes in the stomach. I'm saying it like this because I need to talk in layperson's terms for someone listening. I know you know this, but the PPIs, I think omeprazole is one of them. They actually can contribute to bone loss. So she's been on this, and she has, Barrett's esophagus, Barrett's esophagus is typically diagnosed if they see dysplasic cells. So if they look at the cells in the esophagus and they see that those cells have actually started to change, they could potentially become carcinogenic, right? So someone that has Barrett's esophagus is usually recommends you probably can't go off the PPI. We want to keep that acid from coming back into the esophagus. So she's very naturally minded. She wants so badly to go off them. And she said to me, I really want to try to go off these PPIs. Well, she actually doesn't have dysplasic cells, by the way. But I think in her family, Barrett's exists, so they're kind of potentially thinking that's the case. So she said, I want to go off of this. Now, my recommendation to her is I have to tell her, you need this to be a physician recommended situation. If it were me and this was my situation and I did not have dysplasic cells, and that's usually when you shouldn't go off of a PPI, I would go off of them. I mean, of course, monitored by a physician or somebody that would agree with that. But that's the thing. It's like where it's hard for the individual to make their own decisions.
There are options. There are other ways to reduce acid, less pharmaceutical. There are other mechanical techniques. Most reflux up into the esophagus happens at night when we're flat, right? Because during the day we have gravity to help that. You could sleep with the head of bed elevated. You could not eat for a number of hours, or some of those people can have like a yogurt at bedtime to help quell the acid. You can also take like an antacid, like a Tums or something throughout the day, and maybe a few at bedtime just to quell the acid during the night. There are other ways to attend to it, and then just test it frequently. And some people are simply born with a weak esophageal sphincter where it meets the stomach. So there are probably techniques to train that. I don't know what they are. That's outside my field, but there are probably things to try in the herbal side of the world. And you had me thinking, there's some stem cell options. We could inject the sphincter muscle. It's a little hard to get to, but we could do it, So there are things besides chronic use of pharmaceuticals. Or maybe you cut back on the use. Maybe you take less. Maybe you don't need one every day. I don't know.
Yeah. And so as you were explaining that to me, the options, right? So then if you think about that, that makes sense, right? Critical thinking, brightest minds is what you said to me. We have some of the brightest minds in the country, I believe, or in the world, or in the medical schools, which is true. And I'm going to say probably on the top level of the most respected professions are doctors. And and especially those of us, we've grown up that way.
Not anymore. I think it was at one time, but now I don't think so. I think we're just, I say we. I think a lot of physicians are still cogs in the system, and that's not a thinking position. That should not be respected. And you're right. These are some very smart people who had to get into med school, but it's not the brightest of the brightest who are going into it anymore, and I don't blame them.
But let's shed light on the fact that the training itself that's teaching you to be a critical thinker, that's telling you to analyze the data and to give options. When you're being trained, controlled by Big Pharma, Big Healthcare, funded by Big Pharma, Big Healthcare, and it comes to give them the option, the options are typically pharmaceuticals, and there isn't training on a lot of the lifestyle components of options, meaning the sleep and reducing inflammation and managing stress, two of the biggest drivers of all illness, inflammation and stress.
Yeah.
And there aren't those options. So you're in the office with the bright mind that's trying to analyze this. And then you made a comment that was really interesting too that I want to go back to. You were talking about the disease that didn't exist 10 years ago. Yeah. That is so true. And people don't understand the word idiopathic means we don't know, right? It's an idiopathic thing.
Correct.
And then even I was listening, I'm doing a gut study right now, gut course I'm studying, and we were talking about the irritable bowel and GERD and SIBO, and all of these terms we're coming up with that probably have a pill or a surgery involved, that they're all gut inflammation and dysbiosis
Yeah.
driven.
Yeah. 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 I mean, these are all further elaborations on inflammatory effects upon the GI system, of course. So yeah, we may learn more about it, and the world is more inflamed, so we have more extreme cases that we can study and give it a name. But there are all kinds of new diagnoses. Let's look at cholesterol. We need cholesterol. Okay, you need to have cholesterol. Your cell membranes need that. Cholesterol used to be measured in a normal range from 0 to 240. Now it's measured from 0 to 200. Why? Because so many people are in that 200 to 240 category, get statins. So the statin industry lobbied to have that number reduced. Whereas it turns out now, the controversy is starting to unravel because we've found that the slightly elevated cholesterol levels, well, they're not really elevated. They're just elevated by the new terms in the 200s to 240s, protect against dementia.
Wow.
So take a statin, lower your cholesterol, be at higher risk for dementia. So a doctor has to share that now. That's scientific evidence. But do they? No, not in the system.
Okay. What is acceptable? You said up to 242. I have a lot of women on statins.
Yeah. Why are you on a statin? Ask yourself why are you on your statin. Look it up. You probably don't need it. If you have a cholesterol of 300, okay, great. Take it. But if you're 240, you probably don't need it.
Well, and the other thing is that actually total cholesterol is not, it's a marker for inflammation.
True.
What we
True.
need to really look at is the small particle and the
Yes.
the cardiac components.
Agreed. So all this needs to be looked at. I picked cholesterol as an example. I picked it out of a vacuum. You're absolutely right. I did. Yeah. A comprehensive look is different than a spot look. So the problem is, you go to your doctor, you do very basic labs, and they include a cholesterol, and they put you on a statin. They fix your cholesterol number down. Woohoo! Good job. Got you all better. Prevented you from having a heart attack. No, not necessarily.
Yeah, it's crazy. So if you're going to bake a cake, you need eggs, sugar, flour, salt, and a rising agent. Cholesterol is the flour of your cake. It is the ingredients that not only for that whole cell membrane, but it's the precursor for hormones, for the steroid sex hormones that protect our bones.
Yes. So for those of you at home, cholesterol, steroid. That molecule is the building block for all steroid-based hormones, like the sex hormones for both men and women, like cortisol, and many adrenal hormones, things like that. All those are based on that molecule. You need to have it. I'm not saying go out and eat a bunch of it. I'm just saying that don't be afraid of eggs.
Yeah, okay. Yes, so you made such a good point. So yeah, in the adrenals, because most of us are in menopause after 50 in the bone health world. So I'm just going to speak to that. And by the way that you're speaking is the way that we need to speak, because you and I might understand that terminology and some of this, but a lot of women don't. And so when they go into their physician's office and the doctor says your cholesterol is 220, here's the statin. I think to me, that's what I want to do with this podcast is I want to educate and empower. And if it is the education that empowers women, and I know men listen to this as well. So I'm not, but it's just my population's mostly women. And so the more education that we give people, the more conversation they're going to have with their physicians. So that whole aspect about cholesterol is so important because in the adrenals where the hormone production is happening now, if we're in menopause, we don't have ovaries anymore, so we're not making it there. You do have that pathway of the bone protective, brain protective, heart protective, steroid sex hormone pathway. And you also have that cortisol pathway, which cholesterol is the mother, or well, is it pregnenolone, right? Is it cholesterol, then pregnenolone, DHEA, and then it branches off? So that whole process, we need the stress hormone cortisol to keep us safe, to get up and go if we need to get to safety. And then we need, when we're in the parasympathetic branch of the nervous system, we need to be in the building repairing zone. So we need that. And But that's not known. What is known is cholesterol is a marker we look for. It should be above 200. Here's the pill for it. But what women aren't realizing is what we're talking about, that wait a minute, cholesterol is needed for your bones, your brain, your heart.
You said it right. All these things, the body knows what to do, and we don't want to over monkey with it. I mean, because we're just going to throw something else out of whack.
Thanks for joining me on Stronger Bones Lifestyle. Are you ready to take charge of your future? For show notes, resources, and information on my programs, please visit DebbieRobinson.com. If today's episode empowered you, be sure to subscribe, leave a review, and share it with someone who needs it. Together, we're building stronger bones and stronger lives. Take care, and I'll see you in the next episode.